Everyone. So you may or may not have already heard about Ontario's new guidelines for epilepsy care, but today I really want to focus on what these guidelines mean for your treatment options. So I'll talk a little bit about how you can use these guidelines to make sure that you get the best possible care. I'll talk specifically about some of the treatment options that are outlined. Then I'll talk a little bit about how to maybe have a conversation with your doctor about some of these options. And then I'll talk about some of the key recommendations that are in the guidelines beyond just treatment options. So when you think about guidelines, many things might come to mind. And this is because we are a society that loves guidelines. We have them for everything from diet to exercise to hours of sleep to alcohol consumption. And this is why it's especially surprising that for so long we did not have guidelines for epilepsy care in Ontario. And this means that two people with epilepsy who live in different parts of the province and have different doctors may have been receiving very different care. So you probably know the numbers better than I do. There are over 90,000 people in Ontario with epilepsy. 6,500 will develop it every year. And for years we've been hearing voices from the community saying we need better access to care, we need more consistent care, and we need strategies that apply throughout the lifespan. So we don't just need guidelines for diagnosis. Epilepsy is a lifelong condition. We need treatments and strategies that adapt and change with us. So I'm going to start off with two stories that really highlight the two different journeys that people with epilepsy can take depending on the treatment that they get. So this is Richard. He had his first seizure at the age of 23. After his second seizure, a week later, he went to see his family doctor. He was diagnosed with epilepsy and prescribed Tegretol. Unfortunately, Tegretol failed to stop his seizures, as did the second, third, and fourth drugs that he tried. During this time, he lost his driver's license and his job as a contractor. He continued to see his family doctor twice a week with no change in his condition. He gave up the activities that were important to him, such as his dream of running in the Boston Marathon. And for the next 25 years, Richard tried every drug that came on the market, none of which were able to control his seizures. He continues to suffer from memory problems and depressions. He still has approximately 3 to 4 complex partial seizures a week, and at the age of 48, he continues to live with his parents and has trouble maintaining social relationships. Now let's meet Susan. So she also had her first seizure quite young, at the age of 15. She visited the emergency department and later followed up with her family doctor. So like Richard, she was diagnosed with epilepsy, and in her case, she was prescribed Dilantin. So similarly to Richard, the first drug she tried did not stop her seizures, but at this point, Susan was referred to a neurologist at the local hospital. This neurologist tried a second drug, which also failed to stop her seizures. And this is when Susan was referred to a specialized epilepsy center for further testing. These tests revealed that she was a candidate for surgery, which she underwent 6 months later. Within 2 years of her diagnosis and her surgery, Susan was seizure-free. Now, she continues to take anti-seizure drugs, so she still does suffer from memory problems and occasional bouts of depression, for which she is seeing a counselor, but she continues to work as a teacher and enjoys traveling with her husband. So the difference in Richard versus Susan is not their epilepsy, their seizures, or their diagnosis. The difference is really in the access to timely treatment that they had, the access to specialists to help them find the right treatment at the right time. And this is why guidelines are so important, because they help you to learn not just about your treatment options, but where you need to go for the next step in your care. So there's a myth that guidelines are only for medical professionals. And it's true that sometimes you'll open them up and it's 300 pages of very technical jargon. And this is because historically the interactions between doctors and patients has been sort of a one-way conversation. So the patient goes to see the doctor, they get information, recommendations, prescription, and they go home. It's a one-way flow of information. But in this new model, shared decision-making is being encouraged. So in this model, the interaction between the doctor and the patient is more of a collaboration. So there's still that flow of information, recommendations, and prescriptions, but at the same time, the patient is able to share their thoughts, their values, their opinions, their concerns, and have that incorporated into their treatment plan. So this happens a lot in certain populations already, for example, athletes. So if we take our friend here with the broken leg, we all know that an athlete with a broken leg has a much shorter recovery time than you or I with a broken leg, because they say to their doctor, I need to get back to my sport as soon as possible. Do whatever you have to do. I don't care if I have to have a hip replacement in 20 years. I need to be back on the field in 2 months. And the doctor will take that into account in their treatment plan. So that is something that we should all be doing as patients, because we're all patients at some point in our lives, and our opinions, our voices, our concerns need to be listened to and incorporated into our treatment. So guidelines that are specifically for patients, such as the versions that we have created, are trying to reframe healthcare. So you are being encouraged to take an active role in your treatment, in your care, to find health information, which is easier than ever to find online these days. You can bring that information to your doctor and have a conversation. And most importantly, you should know the standard of care that you should be receiving, because then you can recognize when you are not getting adequate care. So it's about shifting the balance of power between doctors and patients. So I just want to take a moment to acknowledge the creators of Ontario's epilepsy guidelines. This was a group known as the Epilepsy Implementation Task Force, and they were supported by Critical Care Services Ontario. And it was co-chaired by Dr. Carter Sneed, who is a pediatric neurologist at the Hospital for Sick Children, and Brenda Flaherty from Hamilton Health Sciences. Some of you may know Dr. Sneed. He's been one of the leading voices for a comprehensive epilepsy strategy in Ontario for many years. And together they brought together a team of medical and policy experts from across the epilepsy community to come up with a comprehensive strategy to improve epilepsy care in Ontario. So I just want to play a quick video that will give you an overview of the guidelines. I'll just set that up.
Did you know that Ontario has new guidelines for epilepsy care? The guidelines contain evidence-based recommendations to help healthcare providers diagnose and treat people with epilepsy. If you have epilepsy, these guidelines contain important information about your care, beginning at diagnosis. They can help you figure out the next step in your care, or when it is time to get a referral to a specialist. For example, you may have seizures that do not respond to medication. If you are not seizure-free after trying 2 different anti-seizure drugs, you can visit a specialized epilepsy center to learn more about your treatment options. Ontario has 8 specialty centers located at hospitals across the province. Their comprehensive teams can offer you additional tests, such as brain imaging and electroencephalography, to learn more about your seizures. These tests can help find the treatment options that are right for you, such as epilepsy surgery, diet therapy, or different anti-seizure drugs. Epilepsy is not just a seizure disorder. If you are experiencing coexisting conditions such as memory problems, depression, or migraines, your healthcare providers can work with you to develop a management plan. If you are a woman with epilepsy, there may be times when your treatment needs to be adjusted. The guidelines recommend that you visit your doctor to discuss your treatment options if you are sexually active or on birth control, or if you are pregnant or trying to become pregnant. If you have a child with epilepsy, the guidelines provide strategies to help you and your child prepare for the transition to the adult healthcare system. Ontario's guidelines can help you and your healthcare providers to develop a treatment plan that is right for you. To learn more, please visit www.ontarioepilepsyguidelines.ca and talk to your doctor today.
So as you can see, the scope of the guidelines is quite large, but what I really want to focus on today is how to use these guidelines to navigate that diagnosis, treatment, and referral pathway and find the treatment option that's right for you. So let's start at the beginning of the pathway, and this is usually the family doctor. So in the case of both Susan and Richard, they went to see their family doctor first. Many people will go to the emergency room after their first seizure, and from there they'll be told to follow up with their family doctor. So it is typically the family doctor that will diagnose epilepsy, and if they are comfortable doing so, they'll prescribe the first anti-seizure drug. So the guidelines recommend that anti-seizure drugs continue to be the first-line treatment, which just means the treatment that is tried first. And this is because they do work for most people with epilepsy, and it's the treatment that has the fewest risks of treatment side effects. So there are many different anti-seizure drugs available. Your doctor will prescribe one that is specific to your type of seizures and take into account things like your age, gender, etc. So both Susan and Richard followed this first step in the pathway. So what happens if that first drug doesn't work? So in about 50% of people, it will work to control seizures. For the rest, it's recommended that at this point, they be referred to a neurologist. So a neurologist is a doctor who specializes in treating the brain and nervous system. And the guidelines recommend that they are the ones to prescribe the second anti-seizure drug or combination of drugs. And this is where our treatment pathways diverged for Richard and Susan, because Susan went to see a neurologist and Richard continued to see his family doctor. So what about the second drug? What if that doesn't work? So another 13% of people will achieve seizure freedom on the second drug that they try. If seizures continue, this is where it's recommended that you see an epileptologist at a specialized epilepsy center. And an epileptologist is a neurologist who has special training in treating epilepsy. So again, only Susan got to this point in the pathway. So as soon as her doctor realized that the second drug wasn't working, she got a referral to an epileptologist. So why is this point in the pathway so important after you try 2 drugs? And it's not an arbitrary number. So if you look at this graph on the bottom, this shows you the number of the percentage of people that achieve seizure freedom with the number of drugs that they have tried. So as we mentioned, about 50% of people will achieve seizure control on the first drug, another 13% on the second drug. You can see that by the time you try the third drug, the percent it's less than 5, it's about 4%. And this decreases progressively with each drug that you try. So what this means is that if the first 2 drugs you try don't work, there's a 95% chance that no drugs will work. So this is why it's so important that at this point you get referred to an epileptologist. So if you take nothing else away from this talk, this is one of the key messages from the guidelines, that if you have tried 2 appropriate anti-seizure drugs and you are still having seizures, you should be referred to an epileptologist. So you'll notice that I mentioned an appropriate trial, and so there are some conditions to this definition. So some of you may be thinking, well, I've tried 2 drugs, I'm on my third, do I have drug-resistant epilepsy? And there are certain conditions to the 2 drugs that you try. So I'll go over these in a minute, but the drugs need to be tolerated, appropriate for your type of seizures, and taken at the proper dose. So I'll just go through what those mean. When we say that the drug is tolerated, we basically just mean that it's not stopped early due to side effects. So if you take a drug, the side effects are so bad that you stop after a couple of weeks, we may not know whether or not that drug is effective for your seizures because you weren't taking it for long enough. So this may not count as one of the 2 trials. Similarly, the drug has to be appropriate for your type of seizures. So there are many different anti-seizure drugs available. Some work better than others for different types of seizures. So Dilantin, for example, which Susan was taking, can be effective for complex partial seizures. It's not very effective for absence seizures. So it's important that the drug you're taking is the right drug for your particular seizures. And the last criteria is that the drug needs to be taken at the proper dose. So each drug has a specific range of doses within which it is most effective. If the dose that you're taking is too low or too high, you may not know whether or not that drug is effective for you. So sometimes doctors will start very low and gradually build up the dose, but this is also why it's very important to take your medication as prescribed, because if you are missing doses, there may not be enough of the drug in your system to know whether or not it's effective. So if the 2 drugs that you've taken meet this criteria, if they are tolerated, they are the right drug for your seizures, and they were taken at the proper dose, and you continue to have seizures, it is likely that you have drug-resistant epilepsy. And this is the time to get a referral to a specialty center. So the main draw of these specialty centers is that you can have a consultation with an epileptologist, as I mentioned. There are 8 specialty centers located at hospitals across Ontario, 7 of which are operational. And for this audience, the closest center would be at London Health Sciences. So what do these centers offer? In addition to a consultation with an epileptologist, they have an EEG technologist who can record and study your brain activity to find out more about where your seizures are coming from. They have nurses, social workers, psychologists, psychiatrists, and the surgical centers offer a neurosurgeon. So what are some of the things that these centers can do? First and foremost, they can confirm a diagnosis of epilepsy. So there are many things that cause seizures besides epilepsy, and the first step to getting the right treatment is getting the right diagnosis. So if there are underlying medical conditions causing the seizures, these tests can help you to learn more about that. They can check, as I mentioned, if the drug that you're taking and the dose that has been prescribed is appropriate. They can identify lifestyle issues and triggers that might be contributing to seizures. And then if all of this confirms drug-resistant epilepsy, they can offer you treatment options, including surgery, but not just surgery. So some of the treatment options include diet therapy, immune therapy, brain and nerve stimulation, or even continued drug therapy. So I'll just talk a little bit more briefly about these treatment options. So epilepsy surgery, there are basically two types of surgery. One is to remove the area in the brain where seizures are starting, and the other type is to stop the spread of seizure activity. So when most people think about surgery, they think about resective surgery, which involves removing the part of brain where the seizures are starting. So for those who are suitable candidates for this surgery, it does have a good chance of success, so approximately 60 to 80% chance of seizure freedom, depending, of course, on the type of seizures and the location of the seizures. So in order to be considered a candidate for surgery, there are two main criteria that need to be met. So the seizures must start in a particular location in the brain, not in different spots. And this area cannot be located in a part of the brain that is important for things like speech, language, movement, or sensation. Otherwise, surgery may not be possible. So the reason that the guidelines focus so much on surgery is because, not just because it's an effective treatment, but because it's very much underused in Ontario. So in 2012, there was a report that sort of did the math on the numbers in Ontario. And we know that approximately 1 in 3 people has drug-resistant epilepsy. Not everyone will be a candidate for surgery. So this study estimated that there are approximately 20,000 people in Ontario who were candidates for surgery, and only about 2% of them actually underwent surgery. So they looked into why this might be the case, and subsequent studies found that one of the main factors is that sometimes doctors have fears or negative attitudes about surgery that they pass along to their patients. And there's also a lack of awareness on the part of family doctors. So one particular study showed that more than half of family doctors did not know what type of epilepsy could be surgically treated, and almost half did not know enough about the risks and benefits to counsel their patients. Another issue is access to care. So if you're going to be assessed for surgery, you need more advanced imaging, diagnosis, EEG techniques, and not all of these medical centers have access to that. So this is why the guidelines really promote to physicians that if you don't have the capability to perform this type of testing, you need to refer patients to a center that does. Another commonly used therapy is diet therapy. So in most cases, this is the classic ketogenic diet, which is a very high-fat, low-carbohydrate, adequate protein diet where you get to eat things like salmon and avocados and coconut and steak and butter. This is often used in children, but it is an effective therapy for adults as well, and there's currently one adult diet therapy clinic in Toronto at Toronto Western Hospital. So the basis of this therapy is that when the body is forced to use fats instead of sugars, the breakdown of fats produces substances known as ketone bodies, and for whatever reason, these ketone bodies in the brain seem to be effective at preventing seizures. Now, the drawback is that this diet can be unpleasant, hard to maintain, so there are modified diets available that are a little bit less restrictive, such as the modified Atkins diet. Another therapy is immune therapy. So, as I mentioned, there are many causes of seizures. In some cases, it's actually the activity of the immune system, which is the defense mechanism that protects the body, that's causing seizures. So the immune system is usually pretty good at identifying what belongs to our bodies and what is foreign and needs to be attacked. But sometimes, in some cases, it can actually recognize brain cells as being foreign. So in these cases, drugs that suppress the activity of the immune system, such as steroids, can actually stop to prevent the progression of epilepsy. Another common therapy is brain or nerve stimulation. So in this therapy, electrical stimulation of particular nerves or brain regions can be used to prevent seizures. So devices may be implanted under the skin or in the brain, and some common therapies include vagus nerve stimulation or deep brain stimulation. So in general, these types of stimulation are less effective than surgery, so they're typically only considered after either surgery has been ruled out or the person chooses not to have surgery. And a final option is drug therapy, which may seem strange because we're talking about drug-resistant epilepsy. But as I mentioned, there are many different anti-seizure drugs available, many of which have been recently released. And one thing that the epileptologist can do is adjust the type of drug or the dose of the drug and possibly make drug therapy an effective treatment. So just to revisit Susan and Richard, obviously these are very extreme cases, so not everyone spends either 2 years or 25 years in the system, and not everyone who has surgery has a positive outcome. But these two cases are really meant to represent that finding the right treatment for you is critical to finding the best possible quality of life. And one of the main aims of the guidelines is to ensure that people move quickly through the system so that no one has to spend 20 years waiting to find the right treatment. So I want to talk a little bit about how to have this conversation with your doctor, because it's not always the easiest conversation to have. And as industrious as this young man is, it's probably not the approach that you want to take. So we hear either one of two things. People are afraid to talk to their doctor because they don't want to insult them. They say, my doctor's been good to me. I don't want to seem like I'm questioning what they're doing. Or on the other side, my doctor doesn't listen to me. My doctor thinks I don't know anything about epilepsy. So some of the options that you have are to, if you want to talk about a specific treatment option, you can say something like, I'd like to talk about epilepsy surgery. I know that it's effective for some people. Do you think it might be an effective treatment for me? And just start that conversation. If you want to talk more generally about treatment options, you can say, I've been taking these medications for X number of years. They don't seem to be working. Can we have a discussion about other potential treatment options? And so challenges that you might run into are sometimes doctors will say, but your seizures are under control. You're only having, 1 or 2 seizures every month. And so the definition of seizure freedom, remember, is that you cannot have any seizures for the past year. And this is longer if you have infrequent seizures. So even 1 seizure per year is associated with increased health risks. So it's not okay. Secondly, if you have established that you would like a referral to either a neurologist or an epileptologist, ask your doctor what the next step is. Make sure that you have a concrete next step when you leave your appointment. Some general tips. It's always a good idea to write down what your doctor is saying. It can obviously be hard to listen and write at the same time, so it's a good idea to bring someone along who can maybe take notes for you. It's often said, but it's very true, there are no silly questions. You have a right to ask about anything that you don't understand, anything that doesn't make sense to you. Time is often an issue, so most doctors will book very short appointments. So if there is not enough time to ask your questions, ask your doctor if you can have a follow-up appointment to continue the discussion. And lastly, most doctors really want to help. They will listen to your concerns and try to be of help. If your doctor does not listen to your concerns, if you feel like you're being ignored, you have the right to ask for a second opinion. So you can ask your family doctor for a referral to another neurologist, or you can try to find another family doctor. Ontario offers a service called Healthcare Connect that can connect you with a family doctor. So finally, I just want to talk a little bit more about some of the other key recommendations in the guidelines, because not everyone has drug-resistant epilepsy, so these are some recommendations that can apply to anyone with epilepsy. So the first thing I want to mention is coexisting conditions. And of course, we know that epilepsy is not just a seizure disease. There are effects from the anti-seizure medications, and there are effects from the seizures themselves. So there's a whole spectrum of coexisting conditions such as depression, anxiety, learning disabilities, digestive disorders, and these can impact both your physical and your mental health. So essentially what the guidelines say is that these should be taken into account in your treatment plan. So they shouldn't just be dismissed as, well, this is something that you have to live with. Treatments for these should be incorporated. So depression in particular is especially prevalent. Depending on which study you read, anywhere between 30 to 50% of people with epilepsy will experience depression at some point. And so the guidelines recommend that people be screened for depression immediately after diagnosis and then once per year afterwards. And if needed, treatment can include antidepressant medications, which are generally safe to take with anti-seizure drugs, or cognitive behavioral therapy. Another important section in the guidelines focuses on considerations for women with epilepsy. So as the video mentioned, if you are a woman with epilepsy, there are times where your treatment may need to be adjusted. The main reasons for this is because there are certain anti-seizure drugs that can lower the effectiveness of birth control pills or other types of contraception. And if you are pregnant, there are certain anti-seizure drugs that can cross the placenta and may pose risks to unborn babies. Now, the reason that it's so important to have these conversations with your doctor is because obviously uncontrolled seizures also pose a risk to unborn babies. So it's best to work with your healthcare providers to develop a plan that is best for both you and your baby. And folic acid supplements are typically recommended before and during pregnancy to help with the normal brain and spinal cord development of your baby. So essentially, if you fall under any of these categories, if you are sexually active, pregnant, thinking of becoming pregnant, taking birth control, or going through menopause, it's important to talk to your doctor to establish a treatment plan. And the last topic that I want to cover is the transition from the pediatric to the adult healthcare system. So if you have a child who is turning 18, if you are a child that's turning 18, the transition can be a challenge. So in the adult healthcare system, people with epilepsy are expected to be more independent. There may be fewer services and support systems available, so it can be a challenging time. So the guidelines offer some tips for how you and your family can have a more successful transition. So the first thing is that the guidelines recommend that you start this process very early, so approximately age 12. And this is where you can start to gradually shift responsibilities over the next few years from the healthcare providers to the parents and then to the person with epilepsy themselves as appropriate. This may not be appropriate in all cases. And this is also the time where you want to start exploring available services and supports in the adult system. So it takes a long time to gather documentation and to research these services and to apply. Anything related to the government involves a lot of paperwork, a lot of waiting, so it's important to start this early. So around the age of 16 and 17, this is where you can start identifying obstacles that may prevent a successful transition from pediatric to adult healthcare. And the guidelines offer a number of checklists which you and your child and your healthcare providers can use to identify any areas where skills or awareness may be lacking. Now, around age 16 is also a good time to confirm diagnoses. So brains change, particularly adolescent brains, so this is a good time to redo any brain imaging and potentially look at genetic testing if that hasn't been done before. And then the last thing is around age 17 to 18, families should be receiving a complete discharge package from pediatric healthcare providers. So this includes copies of referrals, past treatment plans, documentation for any social and financial support, the goals of treatment, emergency plans, etc. So this is something that's shared with the parents, the child, and the healthcare providers. That was a lot of information, so just to summarize, the key is to start the transition process as early as possible. Again, around age 12 is what's recommended. Research what supports and services are available. The guidelines website does include a link to a lot of these services and supports. You can use those checklists that are in the guidelines to identify areas where skills or awareness may be lacking, and always a good idea to confirm any diagnoses before the transition. So what are the main things that you can do? How can you use these guidelines? So you can read the summaries that we have available if you don't want to go through all 300 pages of the original guidelines. So the summaries are all available online at ontarioepilepsyguidelines.ca. I do have booklets of the guideline summaries. These will be available in the front, and they will be available at any Ontario Community Epilepsy Agency. You can visit the website for more information about some of the things I've talked about today. And most importantly, the goal of all of this awareness about the guidelines is to encourage you to talk to your healthcare providers, to work together with them to develop a treatment plan that is right for you. Your doctors have responsibilities as well. So one of the main things that they need to do is provide you with timely referrals. Okay, so even if your family doctor or neurologist really likes you, they can't keep you. If the treatment isn't working, you need to get referred. They are recommended to follow the guidelines that are provided as appropriate. So obviously every person with epilepsy is different, every case is individual, and physicians are encouraged to use their clinical judgment and not just follow the guidelines as if they were rules. They do need to stay up to date on current evidence, which is changing all the time. And no matter what the opinions of your healthcare providers, they need to provide you with information about both the risks and benefits of any treatments that are options for you so that you and your family and caregivers can make an informed decision. And lastly, they should always provide you with contact information or a referral to your local community epilepsy agency, because they are the ones that can provide support for every aspect of an epilepsy diagnosis. So in conclusion, as we saw with Susan and Richard, often the difference in the quality of the quality of life and your health outcomes is being offered the right treatment at the right time. So this is where the guidelines can help you to identify a standard of care for yourself. So this is where you can say to your physicians, this is the treatment that I'm supposed to be receiving. And the most important thing is to use the guidelines to figure out what treatment options might be right for you and to have that conversation with your healthcare providers. So in 3 words, knowledge is power. And I just want to acknowledge all of the collaborators for this project. So the creators of the original guidelines, the Epilepsy Implementation Task Force, we worked very closely with our partners in the community to help develop these guideline summaries, as well as all of the executive directors of Ontario's community epilepsy agencies. So many thanks to them, as well as our entire EPLink team, because it's been a very collaborative process. And support for this project was provided by the Ontario Brain Institute and UCB. So I'm happy to take any questions, and I am not a medical doctor, so Dr. David Stephen, who is a neurosurgeon at London Health Sciences, has kindly agreed to join me for the Q&A, so if you have any more specific medical questions, he can help with those.
Well, that will be up to the individual physician's office. So, I mean, that's up to the individual doctor. That will be for copying the files and whatnot. Many of us do not do that, but some doctors may choose to charge to copy medical records and couriering them securely to the next location or whatever. Maybe that's what it is. In a hospital, of course, everything's electronic, so we don't bother with any of that.
Yeah, it would be a different process in a hospital, but yeah, it seems like it's just up to the healthcare provider if they want to charge or not.
The typical one would be imaging. So if you have, for example, an MRI scan at one hospital, the hospital will charge you to put it on a CD, for example, or to bring it. But it's really a choice of the individual practitioner or the individual hospital. You don't have to charge for these things. Yeah. Many of the records in Southwestern Ontario, if they've been dictated on like any of the hospital systems, should be available through something that we call Clinical Connect. So even Hamilton patients, for example, I can get all the information online. So, and most of the critical stuff is there. Like, we don't really need to see all the little notes about, from the family doctor about the sore throat and all this stuff. Like the main notes from the specialists are usually in the system.
And this is very much dependent on the neurologist. So one thing that you can do is ask if they are not available to have a follow-up appointment with you, they may be able to refer you to, say, a nurse practitioner, for example, who has this access to the same information and may be able to spend more time with you going through your treatment options. So it really just depends on that particular neurologist, but they have healthcare teams available to them with different types of healthcare providers that can meet with you as well. There are particular types of surgery that don't involve removing a part of the brain. It's more about interrupting some of those pathways where seizure activity is flowing through. Are you covering that at all?
Yeah, I mean, the typical one would be something called a callosotomy. I'll talk a little bit about that, but a great option. We prefer to remove a section of the brain if we can, but it's an option that I'll chat about a little later.
Certain more experimental therapies that are being studied, including medical marijuana. And the guidelines don't have recommendations for these specifically, not because they don't work, but because we just don't have enough information about dosing and safety and efficacy. So the guidelines are updated every couple of years, and research like this, if it's I'd have to read through it, but if it's a well-conducted clinical trial, research like this will be incorporated into future versions of the guidelines so that people know their medication options. Every case of epilepsy is so different, and the right dosage is different. The amount of time that it takes for the drug to work its way through the system, the level in the blood, because each person processes that drug differently, is different. And then, you have the side effects that you're dealing with. So each person's tolerance for side effects is different, which determines, when they might want to stop the drug. So unfortunately, it is, and you have to be taking the drug, I would say, at least 6 months to get an idea of whether or not it's effective. And then depending on the doctor, they might want to add a second drug to that one and slowly sort of titrate the first one rather than stopping it completely and starting another one. So it is a very complex process, and unfortunately it is very time consuming. As long as they know the criteria for drug-resistant epilepsy, though, they shouldn't be continuing, for years on a drug that isn't working or just adding drugs onto the first one. So the guidelines for clinicians, at least, will say specifically, this is sort of a cutoff point. This is where you have to try the second drug, and you don't need to try more than 2, which is usually what keeps people in the system for a very long time, trying 4 or 5 or 6 drugs.
That's why it's complicated. Like, I'm a neurosurgeon, right? So I don't really deal with medications very much. But even if I have a problem with one medication and I get tired of the problem, I send it to one of the epileptologists. That's why they're there, because the meds are complicated. They work differently in different people. They have kind of strange side effects in some people and not in others. And so that's why the guidelines are here. So if the med's not working, send it to one of the epileptologists, and they have dealt with all of these problems before and can figure this stuff out, right? That's why they're basically epilepsy medication specialists.
That particular referral pathway on the side of the patient. So Healthcare Connect, some people have used with success to find another family doctor that can refer anywhere. And then we do have some neurologists who are happy to refer because they say, I have a lot of patients, or I'm too busy, or this person might be better suited for you. So we've heard both sides. Some people get a very positive response when they ask for a second opinion, and others don't. So unfortunately, there is no sort of stereotypical pathway for referrals. I would say a walk-in clinic would be a decent option, and especially when you're dealing with a low concentration of specialists, such as you would be in London or Sarnia. Your options are different than if you're in Toronto, unfortunately. Yeah, so I would probably give the same advice.
Don't take no for an answer.
Don't take no for an answer, absolutely.